Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Bristol Myers Squibb.
Hi, everyone. I'd like to welcome you to the CNE event, CAR T Cells and Systemic Lupus Erythematosus, a New Frontier in Autoimmunity. My name is Dr. Emily Littlejohn, and I'm here with my colleague, Paulo Cami, and we're here to talk to you for the next 35 to 40 minutes about our experience in this space. So like I said, my name is Dr. Littlejohn. I'm an associate professor. I run the lupus clinic at the Cleveland Clinic. And this is Dr. Paulo Cami. He's a professor of medicine here at the Cleveland Clinic Lerner College of Medicine. He is the associate BMT and CT director for cell therapy here at the Cleveland Clinic Cancer Institute. So first, I'd like to give an introduction about systemic lupus. Systemic lupus is a multi-system autoimmune disease affecting primarily women in the reproductive age range. The prevalence of lupus varies considerably by race, ethnicity, and geographic location. Prevalence of SLE in the U.S. has been reported to be between 20 and 150 cases per 100,000 persons, but also as high as 406 per 100,000 persons among Black women. Historically, this disease has been associated with significant premature mortality and morbidity and permanent organ damage, such as end-stage renal disease, heart failure, and interstitial lung disease. The disease course varies significantly between patients due to the high heterogeneity of this disease. There is an accumulation of morbidity and mortality and disability over time. This leads to decreased quality of life or disability. Progressive damage can impair renal, cardiac, or pulmonary function and may result in organ failure and premature death. And while the survival rates have improved over the last 30 to 50 years, the 10-year survival remains 83 to 93%, and the 15-year survival remains 76 to 80%. Treatment for systemic lupus consists of glucocorticoids and conventional or biologic immunosuppressive drugs. This is both to control disease activity and to prevent relapses. As of 2011, we had our first drug approved for systemic lupus, which was belimumab. But prior to that, every single drug that was used in this space was borrowed from another department or another type of medicine, such as lymphoma, leukemia, antimalarials, etc. So as of 2020, we consider this the lupus renaissance, and we had 3 drugs that were approved. Despite these new therapies and this lupus renaissance, many patients remain refractory to treatment. Lifelong medications can lead to cumulative acute and long-term toxicities, and there's a critical need for more effective therapies with fewer long-term side effects. Now I'd like to talk about B cells in lupus and why these are implicated as a good mechanism to target in lupus. So B cells contribute to autoimmune diseases through both antibody-dependent and antibody-independent mechanisms. As you see at the top left here, the antibody-dependent mechanism, which is really the cornerstone driving pathophysiologic mechanism that we think about in lupus. We think about the accrual of autoantibodies, activation of immune complex deposition, which causes local inflammation in our organs, and type 1 interferon production. Now, there's also antibody-independent mechanisms, and these include B cells' ability to present antigens, augmentation of T cell activation, cytokine secretion, and pathways involving the lymphotoxin alpha pathway, mediated pathway, which is crucial for immune regulation, driving B cell proliferation, and antibody production. So not just about antibodies and what we think of as local immune complex deposition. So deep B cell depletion may be an effective treatment. We know the rituximab story. Rituximab is a monoclonal antibody targeting CD20 antigen that depletes CD20 positive B lymphocytes. Unfortunately, in two trials, the Explorer non-renal lupus trial and the Lunar trial, which was a renal lupus trial, did not meet primary endpoints. More recently, obinutuzumab, which is a humanized type 2 anti-CD20 monoclonal, just this past fall, the Regency trial, which was a phase 3 trial, met its primary endpoint. We found that more patients treated with obinutuzumab plus standard therapy achieved complete renal response at 76 weeks versus those receiving standard therapy alone. The difference between rituximab and obinutuzumab is that this type 2 anti-CD20 agent has been associated with higher response rates due to their enhanced ability to induce direct B cell apoptosis and their prolonged serum half-life. So this is a pictorial of the different expression of B cell markers and what to target in the bone marrow of B cells. You see here naive B cells, double negative B cells, memory B cells, and plasmablasts, and the different markers of expression on their cell surface. I think what I'd like to bring your attention to is CD20, which is the rituximab and intusumab story, versus CD19, which targets a larger array of these B cells here in the bone marrow, making this a good marker to look for these therapies such as CAR T therapy. Now I'd like to switch gears and talk about CAR T cells for systemic lupus. Dr. Kami?
Yep. So I'll take over talking about the basic parts of CAR T cells. So uh, CAR T cells are chimeric in the sense that they have a receptor protein that is a fusion protein between the T cell, the intracellular component of the T cell receptor, and a surface receptor that is antigen recognizing domain of an antibody, a single chain variable fragment. And in many of the lupus studies, the target is essentially the same whether they use for B-cell malignancies, which is CD19, which as you just saw is an antigen that is expressed throughout the B-cell development. They're considered chimeric because they have parts of two different organisms, a B-cell component that's on the surface of the B-cell and the T-cell component that's in the internal part of the cell. As you see here, the T cell receptor structure in this diagram, you can see that there's multiple components on the transmembrane domain and extracellular domains, with intracellular domains that are capable of stimulating the T cell upon engagement with an antigen. You see that when you have a CAR T cell, you have a domain that is really the single chain variable fragment that is attached to some of these intracellular domains and transmembrane domains. And we have first generation CAR T cells have only a single co-stimulatory domain. Second generation CAR T cells, which are what are approved currently, have two co-stimulatory domains and allow for prolonged persistence and higher degree of activation of the B cells. Where third generation CAR T cells have more than one intracellular co-stimulatory domain, although they haven't yet been approved and they have not yet shown that they have significant increased persistence. There are fourth and fifth generation CAR T cells that have more complex structures that are capable of secrete cytokines or have certain additional receptors for other granzymes or perforin. So in the end, we end up having a fusion protein, which is the single chain variable fragment in the outside, connected through a hinge region to a transmembrane domain with a costimulatory region, as well as a T cell activation domain that is capable of activating the T cell upon engagement of the receptor. There's multiple different CAR Ts in development. You see towards the left of your screen the two classes of CAR Ts that are approved. Those that target target CD19 that are approved for B-cell malignancies, included ALL, follicular lymphoma, diffuse large B-cell lymphoma, and those targeting BCMA, which is a later expressing antigen on B cells, which is approved for the treatment, which are approved for the treatment of multiple myeloma. There are multiple other antigens that you can see that are being studied for solid tumors, including PSMA for prostate cancer, B7H3 for glioblastoma, and other solid tumors. And these are all sources of hope for potential treatments for malignancies of the solid type. The process for CAR T cells, and you see in this diagram how it works. It starts at the top, where patients get apheresis and they get the leukocytes collected. Usually, we aim for collecting approximately 1 billion T cells on patients. Usually, from the apheresis product, the T cells will be separated to at least two different types of mechanisms. Those T cells will eventually go into manufacturing, where the cells will be activated and an insertion of gene will be done through either a lentiviral vector, retroviral vector, or through electroporation processes in research study. Then if transfected CAR T cells will be expanded, and then will be prepared for re-injection, usually in a form they're formulated in cryopreserved fashion. The journey for the patient starts when the patient gets apheresis. You see here number one towards the right of your screen. Then the cells will be purified. These are the things that happen during manufacture. The majority of the products that we use are lentiviral, though some are retroviral currently in the commercial space. And then the patient will receive lymphodepletion chemotherapy to be able to tolerate and allow for expansion of the CAR T cells in vivo. And after that lymphodepletion chemotherapy, which most times consists of fludarabine and cyclophosphamide, patient will receive the CAR T cells over the course of about an hour or so.
Now I'd like to talk about some preliminary data on safety and efficacy in a very small cohort of lupus patients. What we'll talk about first is the 8 initial patients who were treated who had systemic lupus by Dr. Georg Schett in Erlangen, Germany. And here is the antibody profile of these patients within the first 6 months. So you see here serologically, they have decreases in their anti-double-stranded DNA, single-stranded DNA, the secondary necrotic cells, along with histone, nucleosome, and anti-Smith. And on the right upper, you can see that overall their patient's ANA is lower over time, meaning that their number of autoimmunity in their burden of autoimmunity has been overall turned down. What we see next here is the efficacy at 6 months after a single infusion, in terms of remission. So we have different, acronyms here that we use. The DORIS remission, all 8 patients achieved. The 8th patient achieves this at 3 months. We have the low lupus disease activity score, which all 8 patients also achieved. The SLEDI-2K, which is maybe the more commonly used, remission scoring system, was 0 in all patients at 6 months. All of these patients were glucocorticoid-free, and there was no immunosuppressive drugs that were made or that were used at all at 6 months in any of these patients. So they were truly in a drug-free remission. Next, you can see here a little bit of a 30,000-foot view at 24 months, which is the 2-year mark. The SLEDI-2K remained low, around 0 in all of 8 patients, along with serologic stability in terms of the anti-double-stranded DNA remaining low at 24 months. You see complement levels increase, so there's no local deposition of the complements with the immune complexes. And also you can see those who had lupus nephritis over 24 months, their urine protein to creatinine ratio was low, meaning that they were in a renal remission as well. In terms of safety here, we'll talk about CRS and ICANS a little bit later, but in all 8 of these patients, the worst side effect that was noted was a grade 1 CRS, which could be something like a fever with mild constitutional symptoms, but nothing worse than that. And you see here no evidence of ICANS, bone marrow toxicity, need for glucocorticoids, hypogam status, or need for IgG substitution. So this is a relatively safe process you see here in these initial 8 patients. What about long-term effects of the immunosuppression and infection? Well, within 3 months, you see 3 patients did have an infection, a UTI, URI, and pneumonia. 3 to 6 months, there was also 2 URIs, and you can see as time goes on, 6 to 12 and more than 12, there are a few more URIs that had been reported. I just think this underscores the need for us to be diligent about keeping an eye on the immunosuppressive status of these patients and looking for infections just ongoing. So, who is a good candidate for CAR T trials? And while this is largely protocolized and different for every study, I think the patients that we see who are the most well suited for this kind of better in a larger scale are those who are young, who have acute, severe, progressive lupus, minimal tissue damage, and who have failed many medicines. So, generally speaking, these patients are going to be 18 or older. They need to fulfill the EULAR 2019 lupus classification criteria, which means they need to have positive autoantibodies in terms of an ANA and also more specific extractable nuclear antigens such as a double stranded DNA, a Smith, a histone, or a nucleosome. Of course, this is different by every study, the specifics of what is required. Like I mentioned, they need active disease. This is typically defined by BILAG criteria, having at least one domain in the BILAG be in A, which is the most active domain. But some studies will allow two B domains, etc. They need to have an insufficient response to steroids and at least two other immunosuppressive medicines. Again, this is a general statement here. Depending on the immunosuppressives used, but typically they need to have failed a biologic or things like cyclophosphamide, mycophenolate mofetil, belimumab, azathioprine, anifrolumab, methotrexate, rituximab, OB, etc. Um, in general, patients need to be considered refractory, and that will differ by each study. Some of the contraindications over the large scale are those who have life-threatening end organ damage that is probably not reversible and thought to be more chronic. Those who have an active malignancy, those who have received some type of CAR T therapy in the past, and of course, those that have severe cytopenias or who have uncontrolled infections. Some other things to consider are those who are pregnant or breastfeeding or looking to become pregnant in the short term. And of course, any kind of active malignancy is a big one that we want to make sure is not ongoing in these patients.
Here's my section then. So moving on to CAR T-cell clinical trials, we'll talk about some of the discussion points that we bring up to patients. Number one is talking about the eligibility and the patient journey somewhat. I try to not mess the indications in terms of lupus, but patients need to have severe refractory lupus to have one more major organ be like a severe score, have had, as Dr. Littlejohn already showed, a sufficient response to the prior therapies. Um, Most of the trials are in the component of looking either for second the recommended phase 2 dose or evaluating the preliminary efficacy for the setting. You see that for patients, there's a linear, as you see, linear course of therapy. Patients will be screened and consented, usually by rheumatology. Then they move on to confirmation of eligibility. Then they go to the process of leukapheresis up on the top you see. And at that time, the manufacturing will start. Many times, patients will need some type of degree of control of their disease that will be managed by rheumatology. And once the product becomes available and the real reconfirmation of eligibility is done, and patients receive the lymphodepletion on days -5, 4, and 3, they get a couple of days of rest. And in many trials for CAR T cells, they proceed to be hospitalized to receive the CAR T cells and monitored usually for a period of up to 14 days. Many studies are now still requiring hospitalization that will be for 2 weeks for safety monitoring and making sure the patients don't have any significant side effects that are uncontrolled. They continue with long-term treatment. They have follow-up that is fairly close after discharge until day 29. And then they have a little bit less follow-up for the subsequent months as they less intense follow-up for the subsequent months in terms of regarding looking at the response and their safety. But they continue with long-term follow-up. Most of the studies of CAR T cells require long-term follow-up for up to 15 years per FDA guide. Um, in terms of safety, I think it's important to discuss some of the important manifestations of CAR T cells. Cytokine release syndrome is the most frequent acute toxicity of CAR T cells. They usually happens within the first week of infusion. The classic symptoms are a fever. Patients can have other inflammatory symptoms like myalgia. They can have modest or mild hypotension. In many cases, they'll have a spontaneous resolution or they have a very good response to the initial therapy. And then this other side effect that is important that sometimes causes a lot of distress to patients is the presence of neurologic adverse events. It's called ICANS, which is those immune effector associated neurotoxicity syndrome. It happens a little bit later than cytokine release syndrome. It presents as an encephalopathy that can have a range from just mild dysgraphia to disorientation to seizures to coma, with the vast majority of patients presenting just mild manifestations of encephalopathy with some tremor or disorientation or dysgraphia or headaches. We don't really understand very well the pathophysiology of ICANS, but we understand that they respond very well with steroids, and the vast majority of people respond to this interventional, though, as was we have a couple backup uh, options for treatment of this patient. So we have cytokine release syndrome and ICANS as the biggest toxicities. We'll see there's other emergent toxicities of CAR T cells, particularly CD19 ones, that we're starting to identify as we treat more patients. For CRS, the most frequent manifestation is fever, but you can have constitutional symptoms that can go from chills, fatigue, anorexia. A fever can be high grade, and we've seen people over 40, 42, with intense fevers when they're having severe CRS. And the vast majority of times, it is not that intense. But you can have this can develop into SIRS with hypoxia, hypotension, and some organ failure, which can include respiratory failure, but include cardiac failure, fluid overload, renal and hepatic dysfunction, as well as gastrointestinal dysfunction. And this requires intensive care management, as we've seen. There's 5 phases to CRS. You start with phase 1, where you have the initial CAR T cell trafficking. They're just the CAR T cells are moving towards a destination of where they have to act. And this scenario is probably just eradicating and finding B cells. This phase 2 is characterized by local events. And this is probably more true of tumors, but it can also be of areas where there's an accumulation of B cell. And then you have CAR T proliferation, increases in your local cytokine production, immune cell recruitment, so endogenous cells, primarily macrophages and monocytes. The initial tumor cell killing, again, this is more modeled against an oncology, but this is initial B cell killing and the initial cytokine release syndrome, which may be local and may be subclinical. Phase 3 is really when systemic events occur. This is when we probably start seeing that fever. And then you see more aggressive CAR T cell expansion, increasing cytokine release, increasing endothelial damage and leaking, and the initial surge and organ damage can be observed. Phase 4, it's probably the interface between cytokine release syndrome and neurotoxicity, and it was central nervous system events occur, and it's the entry of cytokines into the central nervous system, the entry of cells and immune cells into the CNS, blood-brain barrier disruption, and ICANS. And phase 5 is really the extinction of cytokine release, ideally with the minimum amount of tumor or organ damage. And in that scenario, there's activation-induced cell death of the T cells, further decreasing the cytokines, further long-term memory transformation of the T cells, and hopefully clinical resolution without sequelae. And you can see here that there's different phases, and you see some increase in the cytokines over time, with interleukin 6 probably correlating best with the time of manifestations of systemic CRS, although many cytokines preceded. And for many of us, we understand that the early phase, when we're giving chemotherapy, is generating a cytokine milieu for the cells to expand, and it is possible that we're setting up the scenario for the inflammatory response, although it's also setting up the scenario for the CAR T cells to work. How do we manage it, and how do we grade it? Grade 1 is just having fever. Grade 2 is having fever and hypotension without vasopressors, or hypoxemia without requiring high flow oxygen. Grade 3 is having requirement for one vasopressor or having high flow to nasal cannula, so a more sick patient. And grade 4 is a patient that is requiring more than one vasopressor, is requiring positive pressure ventilation. How do we manage them? You see here we have a progression. Patient with grade 1 can be managed with just tocilizumab, or just symptomatic management if it's persistent. For grade 2, usually we do fluid resuscitation and tocilizumab relatively early in the management. For grade 3 and grade 4, we include intensive care management. Many times we'll add low-dose steroids, which in our scenario is using dexamethasone at 10 milligrams every 6 hours. And in patients who are in very sick scenario, grade 4 CRS, the intensive care is important, and as well as having intervention with a pulse of steroids with methylprednisolone every 24 hours, which usually we will keep for about 3 days. Many times we will add other interventions at that point beyond interleukin 6 blockade. Neurotoxicity, as I said, is an encephalopathy with multiple manifestations. Classically, you'll find dysgraphia, word finding difficulty. Many times it's the relatives that find that there's something wrong with the patient's personality before the healthcare personnel see it. Patients can be somnolent, but it can progress to a more severe encephalopathy with seizures, vocal motor deficits. Cerebral edema can be seen in certain children with coma and rare occasions. So it can become an intensive care setting as well. Pathophysiology is a little bit more misunderstood. classically, we think that there's a lot of central nervous system endothelial cell activation and disruption with some vascular permeability that can lead to localized edema, blood-brain barrier disruption, entry of the cells, and damage to glia and neuronal tissue. And cytokines, it is less understood whether there's a local event with the Lucas 6 blockade not having a lot of effects. So tocilizumab in this scenario is not known to work, whereas sotaximab may have a potential effect by decreasing the levels of interleukin 6, although it's less demonstrated. And the cerebral edema is also poorly understood. Again, we have a couple of tools for determining how the patient's status is. We do a very simple one called ICE tool, which really asks very simple questions of the patient that it helps us grade it. And it looks for orientation, naming, command following, writing, and attention. We also have grading according to the ICE score, but also the presence of seizures. So patients with grade 1 will have only mild changes, whereas patients with grade 3 and 4 will be unarousable, will have very, very severe encephalopathy. Some of them will have seizures, and many of them will have edema. And a grade 4 will have edema and will have posturing and will be very sick. In terms of our management, again, it's progressive. For grade 1, we really just provide supportive care without a lot of interventions. Sometimes we will use lower dose steroids. For grade 2, when there's lower ICE score, patients will recover delirium. Usually we start steroids. Part of our supportive care includes doing an electroencephalogram, doing imaging, getting help from a neurology consultants, and using antiepileptics, although in our case, we use antiepileptics in prophylactic fashion for patients through the first 30 days. For more advanced ICANS for grade 3 or 4, we use higher dose steroids, using dexamethasone Q10 or Q6 hours, or pulse steroids for grade 4. And in the vast majority of cases, we'll have those patients be seen be managed on the intensive care unit. Sometimes we'll do intubation for airway protection if they're very high compromise of consciousness. Additional interventions for patients who have resistance to tocilizumab or steroids will be cilpaximab, which is a monoclonal antibody directly against IL-6. We have anakinra, which is used in the rheumatology space, which is recombinant modified interleukin-1, a receptor agonist, which is effective in refractory ICANS and occasional refractory CRS, TNF blockade as well, and some occasional use of blockade of JAK-STAT pathways as well with ruxolitinib being an effective intervention. We have other immune events that are important. Hemophagocytic syndrome is a late event, usually in the first month, late occurs in parallel with CRS. So in patients who have CRS, that can occur. It can be severe, it can be life-threatening. In patients with very good active therapy targeting B cells, hypogammaglobulinemia is a known effect, and patients have a high risk of infection, as Dr. Littlejohn was mentioning, and B-cell aplasia needs to be managed. And long-term cytopenias is hematologic toxicity we're seeing with CAR T cells is probably related to baseline inflammation and the effects of the CAR T cells in the marrow, and we're learning how to manage it with growth factors. We see here that of the interventions is anakinra and immunoglobulins for hemophagocytic syndrome, immunomodulation for hypogammaglobulinemia, and growth factors and supportive care for cytopenia.
And now we'll talk about some challenges and opportunities in delivering CAR T therapy and how we do this here at the Cleveland Clinic, as Paulo as my co-I seeing these patients. So prior to CAR T infusion, typically a patient's identified by our clinic within our biobank or our cohort of patients that we're seeing. Also, we get outside referrals or referrals from internally patients who have lupus and maybe from a nephrologist or from another specialist. Patients are educated throughout the process. They're typically screened by our team, and we talk about what to expect in terms of washout, bridging, in terms of a flare, how we're going to manage the flare. And this is all before they are officially consented. Once they're consented, they're set up for their process, which typically the first part of this is talking about the washout period and getting them a slot for cell production. They then go through apheresis or leukapheresis, at which point before that, they are typically off all of their medications, particularly high-dose steroids and a lot of our DMARD therapy. They then undergo lymphodepletion 3 days before, and then they are admitted inpatient for their CAR T infusion. Now, while they're inpatient, our bone marrow transplant unit and the cell therapy physicians, such as Dr. Cami, are the ones taking care of these patients for 10 to 14 days, depending on protocols. So during the inpatient stay, this is very heavy hematology responsibility for these patients. And then when they're discharged, there's a really shared responsibility within the first 30 days, up to 3 months. But within the first 3 days, certainly they're seen by both myself and Dr. Cami in our clinics, and they're followed closely with blood work and monitoring of their ICE scoring, which Dr. Cami mentioned, so their neurologic status, along with their labs. Long-term follow-up is typically handed back over to the rheumatologist. We've been seeing them every 3 months, and then they go back to their every 6-month typical lupus follow-up visits. So this is a big part of the process, is talking to patients about what treatments they can be on before, during, and after, and the washout period, which is a very scary time, understandably, for a lot of patients. So typically, immunosuppressive agents are weaned off or paused, and steroids are decreased to typically 0, but can be in some protocols 5 milligrams. And that's through pheresis and until they get their cells received back. There is allowed for bridging, which means patients can be put back on high dose steroids or medium dose steroids, and some of their DMARDs can be added back as well. Certainly, if they're flaring and they need something more, that's at the discretion of the physician in that time period. After they are administered their CAR T cells, a lot of times, depending on their cytopenias and their if they are hypogam, they are given different types of medications. They typically are given inhaled pentamidine, as we like to avoid sulfa drugs in these patients, or IVIG to boost their IgGs. They also will be seeing ID for vaccines and immune reconstitution, which usually happens, I think, at the 6-month mark. So they are seeing infectious disease at some point to get back on their vaccine schedule. So considerations for mid and long-term follow-up. We want to be vigilant about viral infections or reactivation. These patients undergo immune suppression, and they are immunosuppressed post-therapy due to deep B-cell depletion and lymphodepleting agents that are given before CAR infusion. There's co-management of these adverse events by both myself in rheumatology and hematology as well. Particularly in the inpatient side, the hematologists do a really good job of keeping track of any kind of infections, giving antibiotics, getting infectious disease on board. And then, of course, assessing long-term outcomes, including this immune reset, autoantibody clearance, potential for sustained drug-free remission. This is really kind of vis-a-vis blood work, doing ICE scoring, their neurological status, seeing both rheumatology, hematology, and, of course, our infectious disease colleagues. Limitations of CAR T therapy speak for themselves. There's limited data. Most of these trials are phase 1 or phase 2. And some of these autoimmune diseases, they are going into phase 3. So this is based on small cohorts. The one I showed you was a patient sample of 8. I think here we're about at those numbers, maybe 6. There's complex manufacturing, so limited turnaround, scalability drives up cost. That's always a big issue with patients in terms of knowing when they're going to be able to get the cells and kind of living their lives around that time. And this is not a rapid therapeutic option. So this is not a suitable therapy for patients who are in an acute flare and have impending organ damage. So just in conclusion, CAR T therapy offers potential remission for patients with lupus. Patients need to be carefully monitored for side effects, other complications, and this happens both in the rheumatology and hematology side. Of course, more data is needed as these are early stage trials. And this is really a collaborative effort. Like I mentioned, it's all the physicians who are taking care of these patients, and then when they kind of get into CAR T therapy, it's rheumatology, Dr. Cami in a cell therapy group, and of course any kind of input from other specialists while they are inpatient. And this is really imperative to have this multidisciplinary effort to provide optimal care for these complicated. Well, thank you all for joining, and we'll see you all next time.